Happy Thursday, everybody. Welcome to another session. It's a treat to be here. It always is, to be honest with you. But it has a little bit of a sparkle in my eye whenever it's somebody who I haven't discussed with who's discussing for the first time. And today, it's Magnus's time in the spotlight. Uh, I so vividly remember the first time Magnus and I ever crossed paths directly, as direct as his face can be. Uh, he was one of the very few people who actually had his video on during these Thursday sessions, and I don't know what sparked the conversation. I'm curious if you remember Magnus. But it's amazing how much, first impressions are first impressions. You have to be very careful. They can cause a lot of problems in life when you stick to them forever. But they're real. They're very natural. And my first impression of Magnus is, wow, this is a very, very kind, very smart human being. And in his case, it's not often true for me, but in his case, first impression turned into fact, and that fact has been demonstrated in so many different ways since he's joined CPS. It actually began emphatically when he presented a case of ANCA vasculitis with eosinophilia that was not EGPA, and has continued to bamboozle us, not just with his intellect, but with his kindness and with his hard work. Whenever we recruit new members, I ask in the academy chat if anybody is willing to orient them and meet with them. And Magnus is always one of the first people who's like, "Yeah, count me in. I'd love to welcome in and meet new people." And I think nothing captures that overall CP solver sense better than that moment, I'd imagine. But Magnus, let me hand the mic to you to sort of update folks on how you're feeling, and then we can introduce everybody else who's part of today's session.
Yeah, thank you so much, Robbie. You're way far too kind. But yeah, I'm feeling great. I'm also really nervous and excited for my first discussion. And I also just really wanted to use the opportunity to thank you and the rest of the CP solvers for being such a unique space. I think I've never really been a part of a medical community that, on one hand, consists of so smart and the most intelligent and hardworking people that I've ever met. And then, on the other hand, also creates such a friendly, welcoming atmosphere that really makes it such a comfortable a place to be for a young stage learner like me. So yeah, thank you so much for making this space so unique. I'm
Oh
really
yeah,
really excited.
yeah. On behalf of everybody, it's effortless when people like you join it, right? And it's a self-fulfilling prophecy of the good kind. So, speaking of the good kind, we have Jillian, who is scribing today. Jillian, I'll hand you the mic to say hello.
Hi, everybody. I'm excited to be here with you today and to join Magnus's first discussion and to scribe.
Absolutely. My mind was bouncing a little bit because I was about to make a comment about your upcoming discussion in the near future, Jillian. Very, very excited for it, but glad you're able to join Magnus's today. I'm sure there's a very high chance he'll be there to egg you on when it's your turn in the spotlight. The same is for Shreya, who's doing teaching points. Mike, to you.
Hi everyone, I'm Shreya Upadhyay and I'll be doing teaching points today. I'm really, really excited for the case and looking forward for Magnus' first discussion.
Thank you, Shreya. Last but not least, VMR legend. Alec, Mike, to you, my friend.
Hey everyone, good afternoon, good evening, good morning. Thanks so much for being here. The only thing I'll add to Magnus is that I think it applies to all learners, not just early learners. I'm too old to be considered an early learner, but I did join as one. So yeah, I'm really excited. I feel like I have an exciting case. And yeah, Jillian, I did send you the case in WhatsApp as well, and I'll be sure to post everything in the chat as we go along. But yeah, really looking forward to it. Very excited to be here.
Thank you so much, Alec. Really, I really, really appreciate the fact that we've been spoiled by your cases recently publicly. Privately, we're spoiled by your cases very, very regularly, and I hope that'll incentivize some people to, just like Magnus, turn your video on, present cases, and hopefully we get to know you all better, and you get to hang out with Alec and his super cool cases privately all the time behind the scene. All right, friends, let's take it away.
Okay, excellent. So once we get the whiteboard up, we can get started. This is a fairly data-rich case, but it has 6 aliquots, and the 7th will reveal it just for timing purposes. But yeah, let me give you the first aliquot. So this is a 34-year-old woman coming in with nosebleeds. So she tells you that the night prior to presentation, she developed a nosebleed. She didn't have any trauma. She's never had this before. She said some blood clots came out, which she subsequently swallowed, and this led to some nausea and then vomiting of these blood clots. She used a tissue to plug up her nose, and the bleeding did stop for a little while, but she sort of fell asleep. And when she woke up in the morning and took out the tissue, it was still bleeding and still had some clots. So she decided to come into the ER. And I was on a night admitting shift, so this is when I met the patient. And by the time she got to the ER and they sort of clamped her nose, the bleeding had stopped. And she didn't report bleeding anywhere else. Nothing in the vomit, the stool, the urine, or from the vaginal region. And I'm just going to stop here to collect your thoughts.
I don't think we've ever had epistaxis that's prominent before, Alex. This is awesome. Magnus, what are you thinking?
Yeah, thank you for a great start in the case. So I think whenever we hear bleeding, the first question should really be: is it bleeding just from this place on the body, or is it bleeding from multiple areas at the same time? And it seems like here we have a 34-year-old woman with the isolated bleeding from the nose, at least at this point in time. And so I would be starting to wonder if this like an appropriate bleeding. So we've all had trauma to the nose or had like an infection at some point that made us develop nosebleeds. Or is this like some pathologic in some way? And here there's no obvious trauma or anything, and she hasn't experienced this before. So I would be wondering, is there something local going on inside the nose? Something within the vasculature, or is it more like a systemic issue that makes her more prone to bleeding, like something going on with the platelets or the coagulation factors? Yeah, so that's what I'm thinking right now.
Yeah, Magnus, I think that's absolutely superb. Epistaxis, like vaginal bleeding, is a very common phenomenon that's often attributed to almost near universal factors. And I think in epistaxis, once you see it all the time, like I do, you kind of get dulled to the reality of the big picture. And so I really appreciate you articulating that the big picture is the systematic approach that you outlined. And the vast majority of people, what's happening is relatively unique to epistaxis, and that this is an arteriolar bleed, that these are small arteries and capillaries at the end of the nasal septum that are fairly superficial and then get eroded into by environmental factors such as dry air or local medications that are very common, like topical steroids for allergic conditions. And so I think the vast majority of these patients, what happens to them is the reason they're bleeding initially is they have some environmental trigger, be it the environment itself or a nasal spray that they're using. And so what tends to happen is you can pretty effectively control the bleeding by the appropriate application of pressure and careful attention to the blood pressure. So the blood pressure is key here because the patient is going to bleed at the proportional to the systemic arterial rate because these are arteriolar bleeds. So this is the one instance where you might consider doing something to lower the blood pressure, but of course do so cautiously because the patient is literally bleeding. But I will share with all of you that the main reason that these cases go complicated is one, ineffective application of pressure and ineffective positioning. So you want the patient to be sitting bolt upright and not have them tilting back. There's sort of common lore that you should tilt your head back. I don't know where that comes from, but the more and more you tilt your head back, the more and more risk you have of aspirating that blood. You want to be sitting up and leaning forward, and you want to apply strategic pressure right at the nasal bridge, firmly on both sides, and you do not want to stop for 10 or 15 minutes. So this is one of the few times where a benign condition like this completely consumes me in the emergency room because I think any other form of application or positioning often results in a significant delay of the delivery of the care of the patient. So I don't imagine that since we have six aliquots that we're gonna spend six aliquots talking about the positioning of nasal pressure. But since we're gonna probably go somewhere else based on the fact that this patient is admitted, which is very unusual. Um, Position is key. Sit up, lean forward, and hold firm pressure bilaterally on the nasal septum for at least 10 to 15 minutes. Pseudoephedrine or Afrin is a very, very effective medication. If you do use a couple sprays before you apply pressure, you'll avert serious issues in most of these people. If the bleeding escalates, there are a lot of things that you can do that all have to do with devices in the nose that essentially arrest the bleeding. The major caveat to all this is to be able to try to visualize the bleeding and make sure that it is abiding by the base rate, which is an anterior nasal bleed. Posterior nasal bleeds are very, very morbid because they have direct access to the upper airway and they're hard to tamponade. In these situations, you might need to use very creative things like a Foley catheter inflated in the back of the nose to stop the pressure, which I've never done. More commonly rely on expertise from ENT to avert the bleeding. So it's just some practical things about epistaxis which may or may not come in handy now, but they'll definitely come in handy in real life. All right, Alec, Mike to you.
Amazing. Yeah, I love the sort of management reasoning on epistaxis as well. So let me give you some more HPI. So she reports that a month ago, she was discharged from a neighboring hospital, though she doesn't really remember a lot of the details about what was done or was found during that time. She says since then, though, she's continued to feel pretty poor, and she's had ongoing fevers, night sweats, intermittent chills, and palpitations. But these have been sort of basically the same over this period of time. She hasn't had any rhinorrhea or sore throat. She's had no urinary symptoms. She does report some shortness of breath and a dry cough as well, but this has been unchanged over the last month or two. And at baseline, prior to the nosebleeds, she had poor appetite and nausea, particularly after eating. And this has led to a 20-pound weight loss over the last 3 months. She also has had some non-bloody, non-bilious vomiting, usually 3 times per day, but she can still keep food down. She just sort of reports vomiting randomly. She hasn't had any dysphagia or dinophagia. She's had no abdominal pain or diarrhea, no headaches, vision changes, or weakness, but does think at times that her feet, both feet, are a little bit numb. And she says, notably since leaving the hospital, but particularly over the last week, she's began to develop red spots all over her body. They're not itchy or painful. She's never had them before, and she hasn't had any discharge or bleeding from them. And the remainder of the review of systems was otherwise negative. So I'm going to stop here and get your thoughts.
Yeah, Magnus, I think your schema is going to come in handy. What are you thinking?
Yeah, so I think now we get a lot of more information that we can try to use. So when we hear weight loss, fever, chills, night sweats, those are like symptoms of inflammation or can be. So I would be really worried for some inflammatory disease in this patient. And also it has been going on for maybe 3 months or so. So it's yeah, almost in the chronic, like subacute to chronic period. I think first of all, we would like to think about infections. So getting a good travel history, see if she has any exposure or risk factors. Think about if she is immunosuppressed in any way, getting an HIV test. But then also be wondering if there could be any other kinds of inflammation from either a malignancy or autoimmune. So that's also what I'll be thinking of right now. A lot of her symptoms are quite non-specific. And then we have this nosebleed, which could be pointing to some structural disease in there, but I think more likely when I take this together with the red spots all over her body, I would be worried for something affecting the platelet count, or maybe even the coagulation factors. So getting a CBC is going to be really helpful here, I think. I think that's my main thoughts right now. What are you thinking, Rabih?
Absolutely superb. And I think you really realize that this problem is very, very deep, and you're making a very reasonable prediction about the platelet count. And I'm right there with you. And if we sort of thinking a step ahead, I think it'll be crucial whenever we're anticipating that the platelet count is low, to sort of ask ourselves, are we going to be dealing with an isolated platelet issue or an issue that affects the other cell lines? And once we have this conversation, we could sort of try to predict what we might do as a result of these reflections. But what's your sense? Do you think it's just going to be a platelet issue, or are you going to find more issues in the CBC?
I fear that we are gonna find some form of anemia as well. I think the shortness of breath could be a clue to that. And also just with the severity of her symptoms, I would also expect some anemia from chronic disease at least. Yeah.
Superb. I completely agree with you. I think the chances of anemia not being present are so immeasurably low that it might trigger you from the get-go to start to send some tests to evaluate that. And so now that you have that hypothesis, what do you think it might influence your initial orders for the anemia? What might you add in that you might have not otherwise added?
Yeah, so of course we have the bleeding from her nose, but
Yeah,
I think there can be multifactorial
right.
issues regarding her anemia. I think definitely getting a workup for like hemolysis could also be important with the possible thrombocytopenia as well. And that's my main thought.
100%. Yeah, I think, if you ask yourself, what are the important mechanisms of anemia to clarify very quickly? And I think, of course, as you said, it's really bleeding, which you already know she has, but you want to understand, does she have a consumptive process as well? And I think from the very get-go, you might consider just getting an LDH and reticulocyte count. You might not even do that, but it really will accelerate your case going forward. What's your sense of what the white count is going to be? Are you expecting this to be a pancytopenic situation, or is that a little bit more hard to predict, you think?
Yeah, I think that's hard to predict because if it's it could go both ways. So she could have some bone marrow involvement
Yeah,
that would could cause her white count to be low,
right.
but she could also have like some kind of chronic infection with a normal white count and then anemia and thrombocytopenia.
Yeah, superb. Yeah, I'm right there with you. I think that it's interesting how much harder the white count is to predict than the hemoglobin. And so counterintuitively, while that is a point of friction for us, Magnus, it means that when it does come back, it's probably much more of a profound clue as to what's going on. And because you're open to so many different possibilities, it must mean that a specific number clues you into a smaller subspace. And so I think the anemia is almost predictable. It'll be fascinating if it's hemolytic, and I think that'll give us tremendous momentum. But if we're able to solve this case as a pancytopenic case, will be fascinating. But if we see leukocytosis, anemia, and thrombocytopenia, that's a whole different universe. So I think it's impossible to predict a priori. But I will tell you, my sense is that you're going to have a leukocytosis. And I say that because the patient seems to have such prominent intra-abdominal symptoms that my antennae is up for a systemic disease featuring the hematological system rather than a pure hematological system alone. And that more diffuse symptom complex, especially in her belly and maybe even in her nerves, has me curious about whether there's a little bit more heat outside the marrow that might be captured in a leukocytosis. But this is not hold pressure and wait for 20 minutes and discharge the patient. This is a very, very serious circumstance. So uh, we'll see what Alec has in store for us.
Okay, amazing. Magnus, I'm so impressed how you could take all that information overload and really pare it down to the salient point. So kudos to you. So let's get some more information. So for the past medical history, the patient has HIV. She's been off AR antiretroviral therapy for a few years, but said that she restarted it during her recent admission about 1 month ago. She doesn't have any other past medical history. In regards to her surgery history, she had a VSD repair as a child, but otherwise hasn't had any lingering issues. In regards to medications, she's on Biktarvy, which is bictegravir, emtricitabine, and tenofovir, and also on TMP SMX. She doesn't take any over-the-counter meds or supplements. Her family history was non-contributory. In regards to her social history, she is a formerly had tobacco use disorder, quit about 1 year ago, but does have a 5-year pack history. She doesn't drink alcohol or use any other substances. She lives with her family. She works doing creative art, and she's lived in or visited Texas, Louisiana, California, Georgia, and Ohio, though of recent has just been in Texas. She hasn't had any recent international travel, no sick or recent sexual contacts. She doesn't have any pets, but has had intermittent interactions with a family member's cat, the last of which was a week prior to admission. But she doesn't pet the cat, was never scratched by the cat. She doesn't touch the litter. She sort of just waves at them. So let me give you the physical exam. So on presentation, her temperature was 102.9 Fahrenheit or 39.4 degrees Celsius. Blood pressure was 115/75. Heart rate was 120. Respiratory rate of 18. And she was saturating 98% on room air. Her BMI was 20. So in general, she wasn't in any distress, but appeared ill and a little diaphoretic. She was quite cachectic, very sort of ill appearing, chronically so. In regards to her HEENT exam, she did have some dried blood in her nostrils. Her mucous membranes overall were dry. I couldn't see any sort of exudate or lesions or ulcers inside the nose or the mouth, but the dried blood in the nose made that a little bit more difficult. And she didn't have any posterior oropharyngeal erythema. I didn't notice any thrush. The tonsils looked okay. She didn't have any icterus at all, and her conjunctiva looked fine. In regards to her cardiovascular exam, she was regular rhythm, but tachycardic. She didn't have any murmurs. She had the sternotomy scar. Couldn't appreciate any JVD. For her palm exam, lungs were clear bilaterally, normal effort. For her abdominal exam, it was soft, non-tender, maybe some mild hepatomegaly, but I couldn't really appreciate any other organomegaly. For her sort of MSK exam, no swelling or tenderness, normal range of motion. In her neck and inguinal region, she did have some lymphadenopathy. It wasn't tender to palpation, maybe 1 centimeter, a little bit less, not painful at all. Her neuro exam was benign. ANO times 4, strength and sensation were grossly intact. And then for her skin exam, it was warm, a little bit pale, no appreciable icterus. She had multiple red papular lesions, 1 to 3 millimeters, throughout the bilateral arms and legs, the hands, the face and head, and the trunk. Most were non-tender to palpation. The lesions were not blanchable. Most of them were simple papules, but some of them had larger lesions. The larger ones in particular were noted to have a little bit of ulceration and were a little bit tender to palpation. And I'm going to share my screen and show you a picture. Let's see. Okay, are you able to see that? Okay. And I'm just leave that up there, and that's the end of this aliquot. I'd love to get your thoughts.
All right, Magnus. Wow, we're in for a treat. Thank you, Alec, for such an intriguing case. And Julian, kudos to you for describing all this info. It's a lot. Magnus, what are you thinking?
Yeah, so I think what really stands out to me from this aliquot is the history of HIV, because that really affects our differential, because it really can affect the immune system, and we really want to further on get a viral load and a CD4 count to really examine the depth of her immunosuppression, and then I think with her fever and hepatomegaly, and then these lesions. I'm definitely thinking of like either a disseminated infection or some vasculopathy that's like causing these lesions. Yeah, I think I'm not really sure how to characterize these, but they are painful and palpable. So I'm curious if it's like petechial lesions, some of the smaller ones, and then these are like yeah, also due to inflammation in the vasculature, and that would make me think of things like endocarditis, for example, or other infections, but it could also be autoimmune disease. And then, yeah, finally, I'll just also like to mention that when you have HIV, you're probably also more likely to develop other STIs. So, for example, disseminated gonococcal disease can also cause a rash. Yeah, but there are really it just expands our differential so much with this past medical history.
Yeah, no, I'm right there with you. I think, we have a very hectic inflammatory syndrome and a very vulnerable host. And I think the broad workup that we have to do is certainly notable. I'm curious, maybe we can reflect on one thing and then zoom in on the details. Magnus, what are you making of the fact that this seemed to have developed after she restarted her antiretrovirals in the previous hospitalization? So presumably she is more immunocompetent than she was then. Does that influence your calculus?
Yeah, so she developed while she developed these symptoms, she was not taking her antiviral therapy, or I'm not quite sure.
It seems that during the hospitalization that she had a month prior, she was off those medications, and then she is now presenting to us in the context of actually taking those medications. Does that influence your thinking, or?
Yeah, so it has started when she was like maybe more immunosuppressed, and now she has like started taking them again. I think that maybe that can also affect like how we will interpret the CD4 count and the viral load, because these may have been way lower when she developed this syndrome.
Precisely. Precisely. Yeah, I think this is somewhat counterintuitive, right? To say that somebody is in ill or poor health despite adhering to treatment. And this brings up the concept of immune reconstitution syndrome, or IRIS. Are you familiar with this concept, Magnus?
No.
Yeah, it's a very, very interesting concept, with the idea being that when you bring back the immune system, and the more aggressively it begins, with the main risk factors for symptomatic IRIS being the rate of the drop of the viral load. Once you awaken the immune system, you can have a paradoxical reaction. And that reaction can essentially be awakening the immune system to respond to antigens that previously it did not ignore or care about. And there are a specific subset of antigens that are prioritized in the context of IRIS. And so there's a smaller list of infections that tend to have this phenotype of being sleepy and unknown, and then awakening violently when the patient's immune system is reconstituted. The same is true for some cancers. And so you'll see that this aspect, amongst all the other aspects, is a clue to keep in our back pocket. But I agree with you. I think the aspects are, what are these skin lesions? Why is she febrile? What is the nature of her hepatomegaly? And so ultimately, I think we need to have first an inventory of all the organs involved to be able to make tremendous progress. But I think there's probably two questions before us in real life right now, which is, do we need to do anything empirically? Right now, she's right before us, she's febrile. Do we need to do anything to stabilize her right now? And then two, what are your broad strokes workups to sort of do that organ inventory? What do you think you would do?
Yeah, so I think if we are like considering, if we are fearing for a sepsis like picture, we want to start broad spectrum antibiotics. But if we feel like this has been going on for some months and she's not like acutely distressed, then I think getting the tests and then like really ensure a broad workup while still keeping an eye on her, and then start antibiotics if she like gets worse.
Yeah, superb. I think if you just look at the vital signs in isolation, you would probably cover her broadly. If you put it in the context of her subacute illness, I think you have the argument to keep an eye on her for a short period of time to make sure she doesn't evolve. I completely agree. What do you think you would do in terms of your workup when you're first meeting this patient? What would you send off? In addition to the usual blood work, what do you think you might do advanced, and what do you think you might get in terms of imaging?
Yeah, so I think with this, like with this picture, I would want like a pan CT, probably like a CT chest, abdomen, pelvis, and then also some specific infectious workup, like yeah, syphilis tests and yeah, maybe other STIs, and of course blood cultures and urine cultures and all the usual. Yeah.
Yeah, absolutely superb. I think that anyone who has advanced HIV who is sick like this, your empiric infection workup often includes making sure the patient doesn't have syphilis, but also a very low threshold to consider two infections that have a high diagnostic return rate on blood cultures, and that's an AFB blood culture for the possibility of disseminated mycobacterial infections, and the yield of serum cryptococcal antigen is very, very high. So these are sort of automatic in my mind of getting the syphilis testing, the AFB testing, and the serum cryptococcal antigen almost no matter what. I think if if a cancer is on your mind, getting the tumor lysis panel, an LDH, which you would have gotten with your hemolysis workup, and a uric acid is really, really crucial. And I, like you, I think that would be I would get the basic blood work, get those things, and then reassess what radiographic fingerprint this patient has. I think whenever the disease is kind enough to rise to the surface for you, as it has in this patient, getting experts to study the skin lesions and potentially and very likely biopsy them will also be key. So I would get the pan scan, as you said, get those additional tests, and then be on the phone with dermatology to be like, hey, I think this patient, his condition is going to be elucidated a lot by the skin. Do you mind coming and taking a look? I think those would help a lot. All righty, a lot more to go. Mike, to you, Alec.
Okay, amazing discussion. So yeah, let me give you some more information there. So some basic labs, the white count, and I'll just wait for the whiteboard to come back. Sorry.
So sorry. I didn't realize I had lost the whiteboard.
No
It's all good.
worries.
Take your time.
I don't even know how to.
Diastole in the middle of a complicated case is never a bad thing.
Yeah, and I guess while Jillian's getting the whiteboard back up, do you guys want to talk about the pictures at all?
Oh, yeah. Oh, for sure. Yeah, I completely forgot to do that. Yeah,
No worries.
yeah, Magnus, what do you think about the pictures themselves?
Yeah, so I think it can be so tough to like interpret these like dermatologic findings, but I think they look like papules as they were also described, and then there are some smaller spots that I think could represent petechiae possibly, and yeah, then that's probably what I can say.
Yeah, there's a lot of morphologies there, and I think that the question that I'm asking, like you, is are they vascular in nature in any way? And they seem to be raised. And the fact that they were raised has me worried that they might not represent a deep thrombocytopenia and might represent a disease. And what I mean by that is whenever you have a somewhat umbilicated or even nodular process like they appear to be, that tells you that whatever's going on is really growing and eroding and deep. And so for me, if they are indeed vascular, I think the two main considerations of vascular lesions in patients with HIV are HHV8 related entities, including Kaposi sarcoma, and then Bartonella related disease, hint the cat, namely bacillary angiomatosis. So that's if they're vascular in nature. The ones on the hand have that feature to them. The ones on the forearm look much more umbilicated, which are evocative of a variety of infections that occur in patients with HIV, beginning with viral infections like molluscum contagiosum, but also extending to mycobacterial infections and then fungal infections. The fungal infections include all the dimorphic fungi, but with particular attention to histo and blasto, and then cryptococcus as well. So I think I need expertise to help me figure out, are these really vascular or not? Some of them look like it to me, others don't. I think the range of possibility is a whole variety of esoteric infections that include viral, bacterial, mycobacterial, and fungal, but also the possibility of a vascular neoplasm on the spectrum of HHV8. The issue here is not to assume that these lesions explain the entire picture. In a patient with HIV, the number of diagnoses is often more than just one. So I think I'm holding them as a clue, but making sure to keep track of everything else and not force it into one single diagnosis. All righty, I think we're ready for more.
Yeah, thanks so much. Awesome discussion. So let's get some labs. So the white count was 8.2, 87% neutrophils, 7.4% lymphocytes. So an absolute lymphocyte count of 600. No eosinophilia. The hemoglobin was 7.4 with an MCV of 89. And the platelets were 37, and that was confirmed on a citrated sample. The BMP, including the calcium, and then also the mag and phos were all normal. For the liver chemistry test, the total protein was 7.2. The albumin was 3. The AST was 19. The ALT was 6. The T-bili was 0.4. And the alkaline phosphatase was 55. All normal for our lab besides the protein gap. The CD4 count was 11 with a CD4% of 3%. And the viral load was 400,000. The hepatitis B and C serologies were negative. COVID, flu, RSV was negative. Thyroid studies were normal. A urinalysis was bland. No proteinuria, no pyuria, no hematuria. Urine pregnancy test was negative. The EKG just had sinus tachycardia with a known right bundle branch block, wasn't changed from prior. And the chest x-ray was read as no acute thoracic abnormality. And then I finally had some time to sit down at my desk and pull up Care Everywhere for the neighboring hospital. And so I was able to gather some of the following information for you. So she was admitted for about 3 weeks, and she was admitted and found to have hepatosplenomegaly, diffuse lymphadenopathy, pancytopenia, and some colitis on imaging, which sounds like she had some reported diarrhea at that time, but the patient wasn't able to recall this. And then she had sears of unclear etiology. And she got a core lymph node biopsy, which just showed reactive lymphoplasmacytic proliferation with negative GMS, PAS, and AFB staining. And the flow cytometry was also negative. On some labs, she had some evidence of possible HLH. She had a ferritin of 6,000, very elevated soluble IL-2 receptor alpha. And she had a very extensive infectious workup. The only thing that came back positive was an AFB blood culture for MAC, though it came back following discharge, and the patient wasn't aware of it, and it didn't seem like any of the providers were able to get a hold of her, so she hadn't been on any treatment. She was febrile during that stay, but it seems like she got some ceftriaxone and doxycycline, and the fevers improved/resolved enough, but there was no definitive final diagnosis. And all the other blood cultures were negative. She also had testing for like all the endemic mycoses, Bartonella, EBV, CMV, syphilis, PJP, and gonorrhea chlamydia, all of which was negative. And there was no documentation that she had the rash at that time. And her CD4 and viral load were basically the same as they are right now. And when you go back to talk to the patient, it seems like although she was prescribed the antiretroviral therapy, she had some difficulties with adherence, so wasn't taking them as regularly as prescribed. So I'll paste that hospital, review in the chat, and then stop here to get your thoughts.
Thank you, Alec. Yeah, Magnus, a lot of information here. How are you processing it all?
Yeah, what a really rich aliquot. Yeah, so just starting with her anemia and thrombocytopenia, I think whenever we see those together, we start to think, could this patient have a microangiopathic hemolytic anemia? So I think that's definitely one thing to rule out. So getting a blood smear, look for schistocytes, getting LDH and haptoglobin is important. And just remembering that we can also have two separate causes or like other mechanisms explaining anemia along with thrombocytopenia. And we usually see, for example, thrombocytopenia in septic patients or patients in the ICU. And I think next with her CD4 count at 11, I think that's really, really low and should really make us consider opportunistic infections in HIV patients, and that include TB and other mycobacteria, disseminated fungal disease, histo, cryptococcus, also CMV, so viral infections as well. And I think she got a really like broad workup for a lot of these infections. So I'm still wondering what is the origin of all these symptoms. And I think the former hospital stay with her hepatosplenomegaly, pancytopenia, and then colitis is interesting. I know that both CMV and can cause colitis, and also TB can go to the colon as well. So yeah, so maybe we can use that as a clue, but I'm not really sure how to proceed.
Yeah, I think you're absolutely superb. Your mental model of this patient as having a purely hematological syndrome, and the infections that you prioritize are exactly on my mind. And I think in real life, you would probably proceed by dotting I's and crossing T's and reassessing this broad workup. And I think the mental framework that I'm taking is HLH-like syndrome in a patient with HIV. It's kind of a defined syndrome that we've had the opportunity to practice before, Magnus. A long time ago, Zachariah presented a case of disseminated Mycobacterium avium causing HLH in a patient with HIV, and that might be the diagnosis here. You have an NTM, you have HLH, and so maybe all that she needs is aggressive treatment for both her HIV and this, and it'll go away. And that's very, very possible. But the list of infections I think you're prioritizing are the herpes virus infection, especially CMV with the colitis, and then granulomatous infections, and any one of them can certainly do this. And I think a reassessment of all of them is really, really prudent. At the same time, you might wonder, well, that was a month ago, and she hasn't gotten any treatment at all, really, as evidenced by the lack of antimicrobials for her MAC being prescribed, and the fact that her CD4 count and viral load still suggest that she hasn't had much retrovirals in her. And so asking ourselves, HLH plus infection plus 1 month. And I think that's what's making me wonder, what is the pretest probability that we're going to find another infection in this hospitalization? And it's certainly not high enough to completely park the bus in that category. And so you'd start to wonder, wait, is this a malignant process? And so maybe we can just briefly explore that space, Magnus, about what kind of cancers would we begin to think about in a situation like this? What do you think?
And so I think one bucket is like the HIV associated cancers, and I know that Kaposi sarcoma is one of them. I don't know much, but I think it's like some kind of vascular tumor, sort of, that can make you bleed, for example. And I'm not sure if it can cause some skin lesions. I'm not sure whether they would look like this. But that was one thought. And then I think lymphomas is another category that can also be related to HIV.
Super. Yeah, I think it's you might see the theme here is that the viruses that drive the oncogenesis are probably a helpful framework. So for me, I just anchor myself in the fact that most malignancies in HIV are driven by uncontrolled replication of herpes viruses, namely EBV and HHV8. And HHV8 triggers association with three entities: multicentric Castleman's disease, which is a very reasonable answer here, Kaposi's sarcoma, and then an entity that's the least common called primary effusion lymphoma. The EBV-related neoplasms are numerous. There's so many of them, and those are in consideration here. A very fun pearl that I like to use as a soft clue is the LDH. Patients with EBV-driven neoplasms in HIV tend to have a moderately or extremely high LDH. The HHV8 spectrum of diseases, including Castleman's, tend to have an underwhelming LDH when compared to the severity of the clinical syndrome. So that's a soft clue that can help you go one way or the other. The other clue is whether the lesions in HHV8 related disease tend to have a vascular phenotype to them, which goes back to the skin exam that Alec has shown us. I think it's important not to forget what this patient presented with, and she presented with epistaxis, which I think is sufficiently accounted for by a platelet count of 37. However, there are some sinonasal lymphomas that happen in patients with HIV that are probably important enough that now that we're getting a grasp of what's going on, we might extend that imaging to also include the facial structures. So a lot of work left to do, but I think, yeah, our frame of HLH in an HIV patient, prioritizing infection initially, but trying to think a step ahead and saying, infection for a whole month, maybe we should start to think about cancers. But at the same time, I think acknowledging that there's something very easy for us to do right now, which is to discuss with infectious disease about treating this MAC as a place to start. All right, Alec, what you got next?
Okay, amazing. So I'm gonna give you all the information, and then the next Alcott will reveal the diagnosis. So got some coags. The INR was 1.3. The PTT was 37. Upper limit of normal for our lab is 36. So basically normal. The fibrinogen was 423. The LDH was 286, which for our lab normal is less than 271. The CRP was 18. The ferritin was 1,220 with a TSAT of 10%. The vitamin B12 was low at 190. The total cholesterol and triglycerides were both normal. And a haptoglobin was within normal limits. Did get a blood smear. It showed that the white blood cells are mildly increased in number. They show lymphocytes with reactive forms. The granulocytes have a left shift, including metamyelocytes and myelocytes, but there were no blasts or schistocytes, and the platelets were markedly decreased with some giant forms, but no clumping. For some imaging, she had a CT max face with contrast, just showed some dried blood in the left nasal cavity, but otherwise was unrevealing. She had a CTPE with a few less than 6 millimeter pulmonary nodules in the right lung. No pulmonary embolism. The pleura looked fine. There was bilateral hilar lymphadenopathy, right more so than left. And there was some mediastinal lymphadenopathy as well. So on the right side, the right hilar lymph node was 3 centimeters. On the left was about 1 centimeter. And the mediastinal lymph nodes were like 1.5 centimeters or so. She had some sub-centimeter axillary lymphadenopathy, but otherwise the remainder of the CTPE was fine. And then the CT abdomen and pelvis, she had hepatomegaly up to 17 centimeters. The gallbladder looked okay. She had mild splenomegaly with a spleen of 13 centimeters. She didn't have any masses. There was mild rectal wall thickening with liquid stool, but no clear colitis. She didn't have any uterine, ovarian, bladder, or renal pathology. She had some enlarged mesenteric and retroperitoneal lymphadenopathy, and some mild inguinal lymphadenopathy as well, up to sort of 1.2 centimeters. There was mild dilatation of the portal vein, but there was no evidence of ascites or varices. She had peripheral blood flow cytometry, which was negative. She had an SPEP with immunofixation, which just showed an acute and chronic disease pattern, but no monoclonal spike. The serum free light chains were mildly elevated, but with a normal ratio. And then she had an echo with a normal EF. There were no valvular abnormalities, no evidence of a vegetation. Her right ventricular systolic pressure was normal. And then she had a lot of infectious studies, all of which are negative, but I'm going to sort of read them to you. So she had a Fungitel / beta-D-glucan, which was negative, a quantiferon, which was negative, a toxo IgG, which was negative. She had a treponemal antibody, which was negative. She had a murine typhus IgM and IgG, which was negative. A serum cryptococcal antigen was negative. A monospot was negative. The parvo IgM was negative, but the IgG was positive. The urine histoantigen was negative. The serum coccidioides antibody was also negative. CMV and EBV IgM was negative. IgG was positive for both. She had oral urine and rectal swabs and vaginal swabs for gonorrhea, chlamydia, all of which were negative. The blood cultures were negative. Doesn't look like an AFB blood culture was repeated though. And then she had Bartonella, Hensley, and Quintana, IgM, and IgGs, all of which were negative. So, Jillian, I know that's a lot. I shared it with you, so let me know if you need to repeat anything or you guys as well. And then, yeah, I'd love to get your thoughts here, and then I'll tell you what the case resolution was after that.
Amazing. I think it's a perfect time to sort of mix our thoughts. I just created breakout rooms, Magnus, so we'll just do maybe 3 minutes, but I'd love to be able to learn from as many people as possible. So we'll see you all in just a few minutes, okay? All right, welcome back. So Magnus, I'm sure you've been enlightened by some wonderful people. What was the conversation like?
Yeah, so I was in a breakout room with Gillian, and we were both overwhelmed by information, but for two different reasons. Gillian has to scribe, and I have to discuss. So, um, but um, but I think, yeah, we just talked about that that this is like such a tricky case. We get so many signals here, and it's hard to distinguish what's signal and what's noise. So we see that there's like hepatosplenomegaly and diffuse lymphadenopathy. And we also see this pulmonary nodules, which I'm not really sure what to do with right now. And then, so what I'm thinking is that this could be a disseminated infection, but we did such a broad workup for infection. So with time, that gets less likely, I think. And then the other possibility would be some form of malignancy, like we talked about multicentric Castleman's disease or some kind of lymphoma. That could definitely cause lymphadenopathy and hepatosplenomegaly, cytopenias. One thing I noticed was that the LDH was 286, so I think that's a bit underwhelming for at least for a typical lymphoma, to my knowledge. But I think a tissue, a biopsy of one of those lymph nodes is probably gonna be helpful in this case.
Yeah, I completely agree with you. I think that you would expect somebody who is this sick to have a more bold declaration of where their disease is. And you never wish such severe illness upon anybody, but as a diagnostician, you know the more sick somebody is, the easier it is to find out why. And it sets up a little bit of a paradox, and I think that's probably the source of the information overload, is you're like, man, it's so clear that Alex telling me this person is vulnerable intrinsically based on uncontrolled HIV, and also vulnerable by virtue of their acute dynamic syndrome. And yet, all I'm seeing is some tiny spots here or there. And I think that brings up this concept, which I think is a profound diagnostic clue, which I just want to introduce here. We don't have time to do it justice, but this will be the subject of our Academy session about hyperinflammatory cancers. And the concept being here that these malignancies are small in their size of tumor, but massive in the consequences they induce perineoplastically. And I think this is a very familiar concept in general, especially I think in Vale's world of neurology, where a tiny little teratoma causes a young, otherwise healthy person to almost lose her life. And what I think counterintuitive, Magnus, is to have a perineoplastic inflammation, because we often think that the depth and strength of the inflammation is perfectly linearly proportional to the severity and the magnitude of the underlying disease. And that's what you were discussing with sepsis. You're like, when somebody is this sick from SIRS, I usually find the bug pretty easily. And I found it so powerful that Alec essentially used those words. She was admitted for a systemic inflammatory response syndrome, and yet they couldn't find anything definitively in that hospital. And a whole month later, they couldn't find anything. And so for me, I think the odds of her having something in this hyperinflammatory category is high enough that I think you would want to pursue the best biopsy possible, which is an excisional lymph node biopsy. Now, of course, that may not be feasible logistically, but that's probably the most important test. And this concept of hyperinflammatory cancer illustrates to you why it's so important to remove the entire lymph node. It's because you're looking for tiny pieces of disease, and otherwise in an overwhelming inflammatory response, the disease here is not proportional to its consequences. The question is, how much can you get from a skin biopsy? And I wonder if you'll get a decent amount of information. You might get diagnostic information if you see on the skin biopsy she has features of Kaposi's sarcoma, but you might also get non-specific features of other vascular anomalies that are associated with multicentric Castleman's disease. So with what I know, and I definitely have a lot to learn in this space, I think the skin biopsy can be informative. But even if it shows characteristic Kaposi sarcoma, you may still be wondering, wait, does she have evidence of multicentric Castleman's disease in her lymph nodes in addition to this Kaposi sarcoma? So I'm really, really eager to learn, but I think the most profound diagnostic clue is how sick she appears and how hard it is to find out where it's coming from. All right, Alec, enlighten us, please.
Okay, amazing discussion. She eventually got a skin biopsy of a lesion on the right thigh. And they did a bunch of cultures of it, spirochetal, GMS, AFB, and they also did some staining for HHV8, all of which was negative. But they did a Wharton starry stain, which was suggestive of an organism. And eventually she got a PCR of the skin, and it was positive for Bartonella Hensley. So the diagnosis was bacillary angiomatosis. But as you guys had sort of astutely mentioned, she had multiple things going on. So the lymphadenopathy in part with the stuff that was going on in her lungs and potentially in her GI tract was all felt to be from disseminated MAC. Eventually the patient was treated with a prolonged course of doxycycline and other antimicrobials for the MAC and got restarted on ART and unfortunately is doing very well. Yeah, I just wanted to, thank you for going through that and would love to hear your reflections.
Absolutely amazing. What are your reflections, Magnus?
Yeah, I think it was just an amazing journey and phenomenal case. I really appreciate you presenting it, Alec. And yeah, thank you so much. And also to Gillian and Shreya for scribing and teaching points. Yeah, I really have to reflect a lot on this case, I think.
Yeah, there's a lot of cognitive overload for sure. You know, I've always wanted to see bacillary angiomatosis, Alec. I've never seen it in real life. I think that it's fascinating how it can sneak up on you despite all the negative testing that you outlined to us. I'm humbled yet again because this has happened before. Noah presented a case of not quite bacillary angiomatosis, but of severe Bartonellosis. I forget if the host had any vulnerability that required a splenic biopsy and aspiration to find the bug. In retrospect, I think the cognitive misjudgment that I made is to try to loop everything into one single diagnosis, and I think I think disseminated Bartonellosis could account for everything. I'd imagine the lymph nodes in the spleen. But yeah, I must confess that that the adage of a patient with HIV having multiple different unifying diagnoses that all add up to one entity is one that I constantly have to reinforce. At the end of the day, I think you've proven that with antimicrobials, two of the most well-described infections in patients with HIV, MAC and Bartonella, have taken this patient from really severe illness to feeling great, which is wonderful. And thank you for letting me see BA for the first time ever. Very grateful. I'm curious though, what your reflections are, what this case felt like to take care of in real time.
Yeah, it was very overwhelming. It was like one of my first admits on that night, and I had never seen bacillary angiomatosis. And like you, Robbie, I thought that she had Castleman's. I was convinced that she had Castleman's. I
Yeah.
thought these were cherry angiomas. I think I even called Austin. I was like, I think this lady has Castleman's. And I was trying to, convince the surgeons to cut out her lymph node. But yeah, I think, Mark was all over this in the chat, but she had multiple negative serologies for Bartonella. And in particular for patients that have HIV. And I think this was actually a study out of UCSF, but up to 25% of people that have advanced HIV who have culture or like PCR confirmed Bartonella never develop a positive antibody to Bartonella. And so it just has to do with, when your host is profoundly immunocompromised, they can't form the antibodies properly to get a serologic response. And then, Bartonella, particularly bacillary angiomatosis, just hides in the vascular endothelium and leads to these, vascular lesions that can look like, hemangiomas. And they can also evade the immune system and detection, which may be in part as well about why they may not form an antibody response. So it was a super humbling case. And yeah, I just learned a lot, and I'm so impressed, Magnus, with your discussion. And this case was just cognitive overload all over the place. And to Jillian for keeping up. And yeah, I went down a little like sort of open evidence dive that I'll share with in the chat if people are interested. But it's the one and only case of Bartonella I've ever seen. So it was extremely humbling, and I appreciate you guys bearing with me through all the data today.
Yeah, I think doing justice to the case requires us to sift through the monumentous data, because I think that's exactly how this feels like in real life. And I thought, Magnus, you were so, you were up for the challenge. It's a challenge that that I think we can learn a lot from. That sometimes going through it 3 or 4 times is required to really feel like you got as much out of it as you could. All right, Shreya, Mike, to you.
Yeah, such a great case. Thank you for the case, Alec. So we had 34-year-old female with nosebleed. So whenever we have bleeding, we always think of whether it is an isolated symptom or a systemic thing going on. So in epistaxis occurs due to the bleeding of distal capillaries of nasal septum that erodes with either environmental factors like dry air or nasal corticosteroid sprays. In the patient with epistaxis, position is key. We should try patient lean forward and pinch the nose for 10 to 20 minutes, and then if it doesn't resolve, then we need to do the endoscopy and see the arteries, if we can cautery them, or if it's not possible, we can just pack them, or we can use Foley's, or and the last resort is embolization. So we also had a lot of systemic symptoms like night sweats, fever, chills, palpitations, and lots of pulmonary and abdominal symptoms going on in the patient along with the bleeding. So it was an indication that the inflammation is going on in the and that could be exaggerating the bleeding in the patient. So the patient was diagnosed with HIV, and he has restarted ART just 1 month back, which rose the discussion of IRIS. And IRIS is an awakening of immune system after acute decrease of viral load soon after ART initiation. And the most common causes are TB, crypto, toxo, Bartonella, GBS, PML, and they could be increasing the worsening the underlying infection, or they could be increasing the possibility of unmasked infections as well. So we had a vasculitic kind of a vasculitic and umbilicated kind of rash in patient. And vasculitic rash in HIV are mostly caused by Bartonella and Kaposi. Umbilicated lesions in HIV could be due to molluscum, histoblasto, TB, and crypto. Whenever we have bicytopenia, we should think of MAHA, and we should always consider seeing cystocytes in PBS, and we should do the hemolysis workup. We had a lot of lymphadenopathy and with a negative infectious workup, and with one month of progression of symptoms and 1 month of restarting ART, malignancy arose as a great possibility. So cancers in HIV could be HHV8 driven or EBV driven. HHV8 can present as Kaposi, multicentric Castleman, primary effusional lymphoma, and LDH in these diseases are low. Finally, EBV driven lymphoma could be lymphoma and NHL, and LDH could be high in these. So the diagnosis came back with skin biopsy confirming bacillary angiomatosis. And yeah, it was a great case. And there was so much learning, and it was never enough to.
Yeah, you had quite the job there today, Shreya, but I thank you
And
so much for including the management of epistaxis in the same teaching points as the diagnosis of bacillary angiomatosis. So I think those of you who tuned in for this hour definitely got something along between those two extremes of medicine. What a treat. Magnus, kudos. Congratulations on your first discussion, the first of many, I'm sure. Jillian, I know your wrists and fingers are very tired. We're very, very grateful for the learning. Alec, I can't thank you enough for such an epic case. And Shreya, kudos to you for capturing the entire breadth of medicine in a 3-minute teaching spiel. See y'all later.